Hello, good evening, good afternoon, good morning. I'm Mark Wulkan. I'm the chair of surgery at Akron Children's Hospital. I am recently going there from Children's Healthcare of Atlanta, where we started a program several years ago. And I'm going to be the fortunate beneficiary of a lot of work that was done at Akron Children's before I got there to get a program going. They're about ready to do their first cases. So today I'm going to talk to you about how to start a program within a children's hospital. So I have nothing to disclose. So why do we do this? We all know that obesity is an epidemic and that this has great impact upon the health of the children that we take care of, as well as when they get to be adults. It has tremendous implications to the total healthcare system. Even as we're seeing with COVID, as folks that are overweight and obesity have trouble dealing with that disease. So the real reason to do this is because it's the right thing to do. But a lot of times when you're talking to hospital administrators, they want to do the right thing, but they want to know, is this going to lose money? Is this going to make money? Is it going to break even? We're going to talk a little bit how this program or how starting a bariatric surgery program can actually enhance or at least not hurt the bottom line of your children's hospital. So it's very important that you understand how decisions are made in your organization. There's a saying that once you learn how one medical center works, you've learned how one medical center works. So if you can find a mentor, if there's somebody else in your department, if it's a division chief or your surgeon in chief, if you can find somebody that started a program, it doesn't matter if it was colorectal or vascular malformation or something else, but they'll have some insight on how to get things done within your organization. The other thing you need to do is to find a pediatric champion for bariatric surgery. And there is somebody in your organization that is passionate about these patients, and it may be the person who's who's running your weight management clinic, or if you don't have a weight management clinic yet, it's somebody who wants to be running that clinic. You need to partner with them because they're really going to help you bring the pediatricians along, and they're going to help you build the multidisciplinary team that is imperative for the care of these patients. We do the surgical stuff. And there's a lot of stuff we do before and after, but their partnership is imperative for our success. And the other piece is you need to make friends with your friendly hospital administrator. Finding a partner in the hospital that can help you, whether that's the VP of surgery, the director of the operating room, somebody in the ambulatory world, somebody else who's passionate about getting this program going, but also who knows the ins and outs of your organization. If you remember a few slides ago, I said you need to know how decisions are made in your organization. Well, this will be your mentor through that process. Hopefully you'll be able to find somebody who can really champion this up the administrative chain of command while you're managing the physician chain of command to make this happen. Now, part of this is you also understanding some of the ways that the administrators look at this, and it's understanding your business. Over there on the left side of the scale are all the people in the team that takes care of all of our patients. Now, your biggest cost of any of the program for the most part is going to be personnel, and that's going to be a weigh on the system. Now, if they just look at what you get reimbursed for in the clinic visits, it's not going to make sense. But those clinic visits are going to drive a lot of revenue generating procedures in your organization that you can see on the right side of the scale. And that's probably the operating room is the biggest one. We're going to talk about a little bit about each of these, but radiology, cardiology, labs, everything. And when you put all that together, it should hopefully balance. So if we divide this up into sort of the pre-op, intra-op, post-op area, you can see here that there's multiple procedures, whether it's an upper GI or endoscopy preoperatively. We get a cardiology consult. We used to get EKG and echoes on everybody, but I think we overran them. We're doing too many, so they wanted to just talk to the patients, and they don't do quite as many echoes as they used to. Sleep studies, do lots. You need to warn your sleep center that they're going to get overrun. because we do lots of sleep studies. And then labs. There's obviously a lot of labs before, and then we'll talk about the labs after as well. Now, when you talk to the hospital administrators, sometimes, or certainly in the finance department, our finance department likes to say, well, we don't count downstream revenue. And the reason they don't is because the theory is that if that patient needed a sleep study, if you didn't order it, somebody else would have, and they would have had that procedure anyhow. But the reality is that this population of patients is really undertreated and is really not taken care of the way they should be. Now, one of the things you have to remember is that we're taking care of these patients throughout our whole organization. It's not just for bariatric surgery. They come in for appendicitis. They come in for tubes and tonsils, everything else. So it's really to the benefit of the whole system that we take good care of these patients. But that being said, the chances are that your patient, even though they may have every indication to get a sleep study, and you may think they have really severe sleep apnea, chances are they didn't get that sleep study. So that's going to be in addition to something that would have been done before. Same thing with the other pieces of their workup. And then I'm not going to, we all know that the operation, whether it's anesthesia time, OR time, surgeon fees, those pieces usually do okay for the hospital's bottom line. So we don't have to talk about that too much, but that's really where they make the most amount of money. But all these other things add up as well to really offset what you have on the other side to justify your exercise physiologist and your nutritionist and your psychologist. Because a lot of times, even though some of these folks can bill otherwise, it's really hard to get the insurance companies to pay for that. And then post-op, repeat sleep studies to get them off their CPAP, repeat upper GI or possible GERD surveillance down the line. There's a lot of stuff coming out now, and there's recommendations coming out. No pediatric recommendations, mind you, but there are some recommendations coming out for how we should be surveilling these patients afterwards. And labs, lots of labs. And again, this all helps balance the program and helps justify it to the administration that you should be doing it. So the take-home messages are: you need a pediatric partner, you need an administrative partner, understand your institutional decision-making, and that will really help you with whatever you do down the line. Understand some parts lose, some parts gain. You need to put that all together, and you need to have an understanding of downstream revenue. Thank you very much.